Yes, doctor, you can start.
Yeah.
Your voice is a bit of a disturbance.
Studying about osteomyelitis, a very important topic from NEET exam point of view as well as your theory exams. So we'll go through a few previous years questions.
Sorry, there is bad reception.
My voice is not clear.
Now it is clear, but I don't know with presentation somehow.
Okay. You want me to try once more?
Yeah, please.
Is my screen sharing on or not?
No.
Okay. Uh, okay, yeah. You can see my screen.
Yes. Yes, doctor.
Voice is okay.
Yes.
Okay. All right. I'll start off then.
Yeah.
All right. Yeah. Good evening, everyone. Today we're going to be studying about osteomyelitis, a very important topic from the NEET point of view as well as your theory exams. So let's go over a few previous years' questions first. So one question that was asked was acute osteomyelitis is commonly caused by which of these organisms? It was Staphylococcus aureus, Streptococcus pyogenes, Haemophilus influenza, or Salmonella. Another question that was asked was which of these is a true statement regarding acute hematogenous osteomyelitis? A. Proximal femur epiphysis is commonly involved. B. It leads to septic arthritis of the hip joint if the proximal femur is involved. C. Proximal humerus is the most common site. Or D. Distal tibia involvement has good prognosis. So we'll come back to these questions after the lecture is done. Our agenda for today would be learning about the introduction and pathophysiology of osteomyelitis, the clinical features, management, complications, a few key points that you need to take away for your NEET exams, mnemonics and high yield facts that will help you remember better during your exams, and a few MCQs for practice. So this gentleman on the right side is Mr. Augustine Latin. He was the one who coined the term osteomyelitis, which basically means an infection of the bone and medullary cavity. Waldberger classified osteomyelitis based on the duration and the mechanism. So duration wise, if it is less than 2 weeks, it is called as an acute osteomyelitis. More than 4 weeks, it is chronic osteomyelitis. And anything in between, that is 2 to 4 weeks, it is called as subacute osteomyelitis. Mechanism is the mechanism by which the organism reaches the bone. So hematogenous is via blood, which is the most common mechanism of transfer. Contiguous means the infection is spreading from a surrounding site, which can be, for example, in cases of an open fracture, or it can be associated with vascular insufficiency. Let's go through a few most common spotters first. So the most common organism that is causing osteomyelitis is Staphylococcus aureus. You need to remember this, that in any case, whether it is acute or chronic osteomyelitis, whether it's a patient from a developing state or a developed state, whether the patient has AIDS, diabetes, is immunocompromised, if there are open fractures, or if it's a post-surgical osteomyelitis also, the most common organism in all these cases is Staphylococcus aureus. There are a few exceptions though, which have been written here. So in sickle cell patients, the most common organism you have to remember is Salmonella. However, this is also only in the case of if it's a diaphyseal osteomyelitis. In cases of metaphyseal osteomyelitis, it is again Staphylococcus aureus. In cases of IV drug users, it is Pseudomonas. animal bites, Pasteurella, human bites, Eikenella, and those patients who are undergoing prolonged parenteral therapy, it is usually fungal organisms. The most common route of spread is hematogenous, which we have already discussed. The most common site is the femur, followed by the proximal tibia. In the femur as well, it is the distal femur, which is more common, followed by the proximal femur. This is for children as well as the overall rate of osteomyelitis. However, if you're particularly considering only adults, then it is the thoracolumbar spine, which is the most common site. So now we have Mr. Staphylococcus aureus here to spread the infection. So it goes and affects the metaphysis of the bone. Why the metaphysis? These 3 points are what you need to remember. First, the metaphysis is a highly vascular area, which means it has more nutrition for our bacteria. Trueta had made this hypothesis that hairpin loop arrangement of vessels are present in the metaphysis. This hairpin arrangement, as you can see in this picture, makes the blood flow very sluggish in this area. There's increased stasis of blood. This results in the bacteria easily escaping from the blood vessels into the bone. Hobo's hypothesis was that the metaphyseal area has reduced immunity, which basically means that there are reduced monocytes and macrophages in this area. So the bacteria now has escaped the blood and now has lodged into the metaphysis. What next? So now, after lodging into the bone, it starts releasing its enzymes to start degrading the bone. The bone undergoes necrosis, and this necrotic bone, along with the surrounding debris, results in the formation of an abscess. So abscess, you have to remember, is usually formed on the second or the third day of infection. This abscess continues to form, and eventually this bacteria or this pus definitely has to spread somewhere else, right? So where and all can it spread? So the abscess is present in the metaphyseal region. It can travel through the Volkmann's canals to reach subperiosteally to form something called as a subperiosteal abscess. So as we all know that the bone is supplied by the periosteal blood vessels as well. Once this subperiosteal abscess forms, the bone that is there underneath the periosteum undergoes necrosis. This bone undergoing necrosis eventually forms dead bone, which is known as the sequestrum. So now our body also has to respond, right? So what our body does is it forms new bone outside this abscess area, which is called as the involucrum. The pus then eventually travels through this involucrum. It makes small holes in the involucrum known as the cloaca, and then reaches the subcutaneous tissue and the skin to eventually form a discharging sinus. This eventually leads to chronic osteomyelitis. So this is one mode of spread. Where else can the pus spread? So the pus can eventually track down the canal, the metaphysis can go into the diaphysis and eventually infect the rest of the bone as well. One more mode of spread is most of the metaphysis is usually outside the joint cavity. However, in areas where the metaphysis is within the joint cavity or the metaphysis is intra-articular, this pus can go into the joint cavity and cause septic arthritis. Examples of such areas are the proximal femur, where the metaphyseal area is part of the joint cavity, as well as the shoulder. So these are the mechanisms by which the pus can spread. So now what are the clinical features? What will the patient present to you with? In acute case, well, definitely since there's an infection, patient will present to you with fever. And then there are the 5 signs of inflammation. That is rubor, which means increased redness of that area. Calor, which is increased temperature. Dolor, which means increased pain. Tumor, which is swelling of that area. And functionalacia, which basically means inability to use that limb, or pseudoparalysis. Why is it called pseudoparalysis? Pseudoparalysis is basically because the patient does not move the leg because of pain, and there is no actual restriction or no deficit in the neurological system. So other causes of of pseudoparalysis are as follows, which you need to remember: septic arthritis, scurvy because of subperiosteal hemorrhages, which can cause pain, as well as congenital syphilis. What you need to remember is that the pathological hallmark of acute osteomyelitis is the presence of an abscess. Now coming to chronic osteomyelitis. So chronic osteomyelitis, the patient will present to you with discharging sinuses and discharging bone chips. They keep developing swelling followed by discharge. It forms a repetitive cycle. So what exactly happens is that the sinus is walled off, or the mouth of the sinus is closed off by our body. This results in the pus continuously building up inside, and this results in increase of the swelling. Eventually, Eventually, what happens is that this pus comes out through the same sinus or through a new formed sinus, resulting in the entire pus coming out. Once that pus comes out, once there is discharge, the swelling comes down and the patient's pain also comes down. This on and off swelling followed by discharge is also known as Wallenkamp phenomenon. In chronic osteomyelitis, the clinical hallmark that you need to remember is the presence of a sinus. So any question where they ask you and there is a patient presenting to you with a discharging sinus, your first thought should be the presence of chronic osteomyelitis. The pathological hallmark of chronic osteomyelitis is the presence of a sequestrum. So let's learn a little bit more about the sequestrum. So sequestrum, as I've already told you, is nothing but dead bone. On microscopy, there are no Havenstein canals. You have to remember that. And there are two surfaces, the outer surface, which is smooth. This is usually because it's constantly in contact with pus, and the inner surface, which is rough, which is because of the contact with granulation tissue. So this is a high yield table that you need to remember for your exams, basically defining the different types of sequestra that can present in different conditions. So how do you diagnose acute osteomyelitis? So there are three different methods of diagnosis. First is the blood investigations, which are usually supportive. So blood culture, you have to know that it yields positive cultures only 50% of the time, even though if it is a hematogenous spread of infection. The WBCs, definitely the neutrophils in acute and the lymphocytes in chronic osteomyelitis will be elevated, and ESR-CRP will also be elevated. Serum procalcitonin is a sensitive and specific marker for infection, not particularly for osteomyelitis, but for any infection, it is a sensitive marker that can be used. Radiology wise, if the patient presents to you within 24 hours, if the question gives you that the patient is presenting to you because of pain in the leg since the past 24 hours, then the investigation of choice for you will be an MRI. It is an extremely sensitive investigation, and the finding that you will get is the presence of marrow edema. X-ray wise, you can see changes within 48 hours. The first change that you see is just a soft tissue shadow or a lucency. If you have to see any bony changes within X-rays, it usually takes about 7 to 10 days for that subperiosteal abscess to form or the periosteal reaction to come. Radioscintigraphy can also be used. Basically, there are three markers, the indium 111, which is most specific, gallium 67, and technetium 99 methylene diphosphonate. These three markers stick to the WBCs and help us in localizing the focus of infection. Now, if they ask you what is the gold standard for diagnosis, it will be a biopsy. Basically, as we have discussed, that the pathological hallmark of acute osteomyelitis is the presence of an abscess. So the aspiration of the pus from this abscess is the gold standard for your diagnosis. Yeah, is that good enough, Monish? Are you there?
Yes, doctor, it is good. So,
Yeah,
MCQ, uh,
yeah, sorry. You're saying something?
yeah, MCQ you discussed, right?
Okay, yeah. So MCQ wise, again, see my whole point is that we start off with a few questions every lecture so that they know what and all can be asked.
Okay,
And then
okay.
once the lecture ends, for example, in this case, acute osteomyelitis, as we already know and we have discussed, most
Mm-hmm.
commonly caused is Staphylococcus aureus. Okay.
Okay,
And this question, as we know, more than proximal femur, distal femur epiphysis, metaphysis is commonly involved. So A is cut out. And then again, C is also cut out for the similar reason because distal femur is more commonly involved. B, where it leads to septic arthritis of the hip joint if proximal femur is involved, is correct because we have discussed that the proximal femur is intra-articular. So intra-articular metaphysis, if there is osteomyelitis, it can lead to infection of the joint as well and lead to septic arthritis. So B here will be the correct option.
Okay. Okay, doctor. Yeah, it was good enough. But since you have a,
Okay.
okay, I'll just stop the recording.